Hi, everybody. Thanks for having me, Vaughan, and other organizers. So I'm going to be talking about labeling and effects in psychiatry. I'm a philosopher, not a sociologist. And the title of my talk is "A Rose by Any Other Name Would Smell as Sweet," with a question mark. So I am coming from this slightly differently. I'm not going to be talking that much about the functional organic distinction. I'm going to be talking about the brain disorder label, because that's what I've been working on. And there's obviously quite a lot of crossover there, as we will see. So brain disorder labels, or labels of something as organic dysfunction, are often sought out, for example, by certain patient advocacy groups, but they're also often rejected and warned against. So they're pretty controversial. And what I'm going to be interested in this talk is how labels, often wrongly, influence both self-perceptions, but also the perception other people, including clinicians, have of people suffering from psychiatric conditions, and then immediately also influence behavior. So labels and names, and I'm taking this to be uncontroversial, matter an awful lot in the mental health context, which is why I picked my title, because a disorder by any other name isn't quite the same as a rose by any other name. There seems to be effects on how a disorder manifests, at least to some extent. And I'll talk a bit about how that looks. So as a philosopher, I'm going to be drawing on empirical literature and also on the philosophical literature. And I should say that I have, one of my other main areas of research is moral responsibility, so I'm particularly interested in effects on agency and perceived moral responsibility. Okay, here's our plan. I'm going to very briefly talk about why we might want to call psychiatric conditions brain disorders. I could give a whole talk on that. I'm not going to. So you're going to have to take that on faith to an extent, because otherwise we're never going to get anywhere. Then I will talk about taking effects into account and some arguments for and against brain labels, so brain disorder labels. Then I'm going to present a few empirical data that I got from the literature on what the effects seem to be. Then I'll explain possible negative effects, and kind of wrapping that into the conclusions, I'm going to talk about how we might be able to counteract certain negative effects. Okay, so why would we want to call a psychiatric condition a brain disorder? So like the functional and organic distinction, the brain disorder label is contested. People don't agree on what's a brain disorder beyond paradigm cases. They use the term differently. We do agree on some cases. So most people agree that, I hope all people agree that a brain tumor is a brain disorder, that Parkinson's is a brain disorder. But it gets vague very quickly. So for example, when we talk about schizophrenia, when we talk about psychosis, people already become less sure. And I'm going to assume that it's justified to call a condition a brain disorder on a sort of level of content. We're going to worry about effects in a minute. If we find dysfunction at the level of the brain, if we find something that works differently and that is associated with a psychological symptom. And what I would like to stress is that that doesn't entail a commitment to brain dysfunction necessarily preceding psychological dysfunction. That can be the case, but doesn't have to be the case. It also doesn't entail a commitment to saying we need to be able to say there's something wrong with the brain independently of us having found out that it realizes a certain psychological dysfunction. So if we find a certain pattern and we find out that that will always be associated with a certain psychological dysfunction, that's good enough. And I realize that the always is a very tricky one there, because it's very hard to tell whether you're going to find a case where you have a brain pattern without the psychological symptoms until you get there. And we've got a number of researchers from different areas who think that we will find brain dysfunction in most mental disorders. We have some people who think we already have in a few cases. We have the programmatic version in Insel and Cuthbert when they changed to the RDoC, to the research domain criteria, as a way of thinking about areas of functioning in psychiatry and mental health. We've got a recent paper by, a piece by Camilla Nord in Psyche, so a popular piece where she says depression is a brain disorder. So we find a lot of people who think that psychiatric illnesses are brain disorders, but they're not trying to say that therefore they're all like a urinary tract infection that leads to psychological symptoms the way they did in Gareth's example. So it's a broader understanding of brain disorder. Okay, so why might people think it's a good idea to call something a brain disorder over and above correctness? So now we're concerned with effects. So both clinicians and patients are very alive to practical implications, or I should say maybe perceived practical implications of psychiatric labels. And I'm going to give you, and quite a few examples that I'm going to be using are from the context of addiction. The reason I'm using addiction as an example is because we have a very lively debate on whether we should call it a brain disorder or not. Some people come down very heavily on calling it a brain disorder, and some people think that's a terrible idea, and that's why I'm using it. It's always easier to talk about these things if we have an example in mind. So here's Alan Leshner, 1997, in his paper called Addiction is a Brain Disease and It Matters. So he says, the gulf in implications between the bad person view and the chronic illness sufferer view is tremendous. As just one example, there are many people who believe that addicted individuals do not even deserve treatment. This stigma and the underlying moralistic tone is a significant overlay on all decisions that relate to drug use and drug users. So the idea is we're going to be more compassionate with people, more understanding of the problems they face if we call it a brain disorder or disease. Here's another example, and I'm getting this partially from Vaughan and colleagues' paper on the functional organic distinction. They point out that often organic diseases or brain disorders have a higher prestige if they're considered to be more somatic. And one example where we can find that is in the debates about chronic fatigue syndrome, where there are certain patient advocacy groups which are really very intent in wanting that to be considered not a psychological condition, but one that is a neurological problem. So that's some reasons for. Oh, and one more that I would like to say, and we get this a lot when you just look at Facebook posts by patient advocacy groups or people who just want to sort of do the right thing, if you like, where the idea is, if we're calling it a brain disorder, we're both calling it a proper disorder, and we're showing that there really is something wrong with the person. So it seems to be that people think it's more tangible if we can find brain dysfunction of whatever description. Okay, so that's some reasons why people like that label, but a lot of people don't like the label. And in fact, I was surprised at just how upset people get about this topic when I started working on it. So here's what Carl Hart, who's a neuroscientist in the US, says. He wrote an opinion piece in Nature saying that brain disorder labels for addiction are stigmatizing and have bad effects and lead to bad policies, because he says what happens if we call it a brain disorder, then we're sort of basically thinking of it as chemical, biological, and we ignore the societal factors that explain why people may become addicted and why they find it hard to give up drug use. And that means that our treatment and our policy won't be targeted in the way that it ideally should be targeted. Then another worry is that if we call something a brain disorder, that leads to an othering of people. So I know othering as a verb is a strange phrase, but it's been commonly used these days, so I'm hoping that's acceptable. So the idea is that you perceive somebody as more different from you, and that leads to a desire for social distance from people suffering from a brain disorder. And if that's the case, that's obviously a bad thing. And then a further worry, and that's particularly pronounced in some of the discussion around addiction, is that if we think of something as a brain disorder, that will undermine perceived control and affect behavior in undesirable ways, and therefore also immediately affect treatment success. So I'm I referenced the obesity example by Hoyt et al. In 2014. So they did a little study when there was a change to calling obesity a disease rather than just a way, something about body weight. And they found that that had positive effects on people's self-perception. So they felt like they weren't to blame because it was a disease. So some positive effects, if you like, but that it also had undesirable effects on plans for healthy eating. So this is just a very small study, and nobody really knows what people went on to do after reporting their planned food consumption over the next period of time. But at least the snapshot seems to show that there was positive and negative effects, emotionally positive, but behaviorally maybe not so much. And the worry is that that might happen more generally with brain disorder labels as well. Okay, so here's what I would say is a natural thought, which is that you might get mixed effects if you call something a brain disorder. You might think that it would lead to decreased blame because people think they found or know that there's something different and dysfunctional in the brain, but the flip side of that might be that we also have a decreased belief that the person will be able to either recover or manage their condition or control their behavior, and that's obviously not a desirable effect. But it's an understandable one, because if you think about it, if our responsibility judgments are reliant on perceived lack of control, and the lack of perceived control is the reason that we're sort of dialing back on blame and thinking that it's somebody's own fault that they're addicted, for example, then that will naturally come with a certain amount of pessimism about the ability to manage or improve the situation. And so the worry is that even though it's sometimes justified, a judgment of reduced responsibility can easily slip into undermining agency. Okay, so I've given you an overview of some of the arguments that we find for and against using the label. But one thing that we might want to check is what effects we actually find. And obviously you can all introspect now, and that would be interesting in the discussion, but there has also been some empirical research on this. There's been 2 meta-analyses on people's association with biogenetic explanations of mental disorder. I realize that a biogenetic explanation of a mental disorder is not the same thing as saying it's a brain disorder, but it's sort of in that general area, and we have to work with the studies that we have. And what they found is decreased blame, but also an increased perception of dangerousness and a desire for social distance. And that's what Corrigan, who works on schizophrenia as well, calls the mixed blessing model, that you get sort of some positive effects for the person suffering from the condition, but also some negative ones. Then there's been a more recent study by, now I don't know how to pronounce it, Lofman, possibly, and Haslam from 2018. And they looked at specifically neuroscientific explanations of mental disorder. And what they found was no effect on blame one way or the other, greater perceived dangerousness, and a greater desire for social distance and more pessimism about a likelihood of recovery. Okay, that is not wonderful, but that's what they found. Now here is something very, very strange. So when you look at specific conditions, and the one that I was focusing on was addiction, then if you look at what people actually believe about the brain in addiction, you will find a lot of agreement. So you'll find that they agree that there's changes in the dopamine system, for example, but they still, some of them want to call it a brain disorder, and some of them say, no, that's a really bad idea. So what's going on there? If people agree that there are significant changes in the brain, and they also agree that they underlie psychological symptoms, so for example, particularly strong cravings, why do they think that the brain disease or disorder label itself will be pernicious? So why make that jump if we kind of agree on the brain data? That seems like a very odd thing to do. And I'm going to talk you through 2 possible explanations, which I think are both probably partly to blame for what's going on, and then I'll talk a bit about how we might be able to dial that back. So there's a thing called intuitive dualism, and that's basically a theory about how people are psychologically constituted when they think about minds and the social world as opposed to physical objects and the way things roll down a hill, for example. And so there's a psychological hypothesis that we conceptualize minds and physical objects in fundamentally different ways, that we have different cognitive systems for thinking about them. And the idea is that that means that if we give something a biological or brain-based explanation, it gets put into the objects in the world category and taken out of the minds category. So that it seems that people have a tendency to think of these two ways of describing what's going on as mutually exclusive. So the idea is that you might jump from hearing that something's a brain disorder to thinking it's a mechanical defect, and that means that the person's behavior is no longer reasons responsive. And we get this idea in a few different places. Green and Cohen, who are philosophers stroke neuroscientists, have been advocating it. We also have some work by Haslam on this kind of stuff. Okay, let's just assume that we are intuitive dualists, okay, for the sake of argument. I think then we should still not go the way that intuitive dualism pulls us. Here's why. So, if it's the case that brain-based explanations erode our notion of agency and responsibility and of sort of the mind playing an important role, then that should be happening across the board. And in fact, that is what Green and Cohen argue in a paper about how neuroscience will affect the law, and because they think that once we start thinking about the mind neuroscientifically, then we will think of behavior mechanistically, and we'll stop thinking of it as people acting for reasons, and we'll have to give up on moral responsibility and on free will. Now, I think that's wrong, but what I do think they're right about is that if you think looking at behavior in a brain-based way poses a challenge for responsibility and agency because of dualism, because you think about it in terms of a different model, then it's going to cause a problem across the board. That means you have to make a decision whether you think neuroscientific explanations will undermine our notion of us as reasons-responsive actors, and if you think in general that's not the case, then you shouldn't think that in the context of psychiatry. That doesn't mean that psychiatric illness cannot have bad effects on your reasons responsiveness, that brain trauma doesn't have effects on your executive functioning, but we can describe these problems on a psychological level as well. It's not like we all of a sudden throw a switch and we cannot describe on a psychological level that there's problems with agency. And that's really, really important. Now, here's a possible response for somebody who doesn't like what I've just been saying. And it's not a bad response, I have to say, in as far as it's a response based on people's psychology, because you might say, yeah, that's all well and good, Anneli, that might be theoretically true, but we only pay attention to these kinds of neuroscientific explanations in the context of psychiatry when something special is going on. And that's why we're getting that effect there and not across the board. I think that might be true as a description of how we think, but I still think we should aim for more consistency in our thinking, and if we do that, then this effect should at least be mitigated. I'm not saying we can make it go away altogether, but it should at least be mitigated. Okay. So here's another possible explanation for labeling effects, and that is the way we depend on paradigm cases in everything we do. We do analogical reasoning all the time. So when we understand something new, we understand it in comparison to something that we already understand and that we have a reasonably good idea of. The idea is if we think of certain paradigm brain disorders, they do sometimes undermine at least some parts of our agency. and they are relevantly outside our control in certain ways. So I'm going to read you a quote from Sattel and Lilienfeld, who object to calling addiction a brain disorder. Okay, so what they say is, no amount of reward or punishment can alter the course of, say, brain cancer. It is an entirely autonomous biological condition. Imagine threatening to impose a penalty on a brain cancer victim if her vision or speech continued to worsen, or to offer a offer a prize of 1 million if she could stay well. It wouldn't matter. So the idea is certain paradigmatic brain disorders are only treatable by a direct intervention on the brain. And brain cancer is probably the best example of that. And what can happen is that when we hear that something's a brain disorder, we start thinking about other brain disorders we know, and we start making associations as to what's likely to be the case, what's likely to follow from that. And this is particularly pertinent in the context of addiction because, as these two authors in particular stress, patient engagement and the steps that the patient take are crucial for recovery. So it's very different from the brain cancer case in that respect. I just wanted to stress, because it gets very confusing in this area, that just because you say that in a paradigmatic brain disorder like brain cancer, you can't on your own with anything that you do get better, that doesn't mean that there's no control over action. There's a very common temptation to go from, is somebody responsible for being ill? Can somebody do something to recover from their illness? To, is somebody responsible for a certain action that might be influenced by the fact that they're ill? Can they control certain actions that are influenced by the fact that they're ill? And we don't always have the same answer, and I would argue very often we don't have the same answer to those two questions, so it's important to keep them separate. Okay, so the reason I brought this up was because I said, well, maybe the fact that we start thinking about classic brain disorders is a reason why we start applying things to addiction or schizophrenia that we shouldn't really apply. And as I said, we can't help but think in analogies. But what we should do is we should try not to overstretch the analogy and see how far it goes. So for example, even if you think of paradigmatic brain disorders, not all of them are the same. They aren't all progressive, for example, even though, for example, Parkinson's is. And this is an example that was actually given to me when I was talking about related stuff a while back. It's even the case that some fairly paradigmatic cases require intentional action as part of the recovery process. So if you think about stroke rehabilitation, there's an awful lot that the patient needs to do in order to retain speech abilities and so on and so forth. So it's not like they're passive with relation to that condition, even though stroke is it's a brain injury maybe more than a brain disorder. So what we can do and what we should do is both see how far an analogy goes and try to broaden our diet of analogies and say, okay, well, it might be like cancer in this way, but it might not be in that way, and it might be more like stroke in that way. Okay, am I too fast? No, I'm kind of okay, right? So I will draw some conclusions now. So I would say that in principle, I realize that practice is a bit different, but I'm a philosopher, so I'm allowed to take a fairly high-level view of these things. We should be able to avoid at least many of the negative effects of the brain disorder label. But then the question is that practically realistic? I've given you the case for mitigation of the bad effects. I'm now giving you the case against mitigation. I've already said that intuitive dualism is, in my opinion, misguided. We can theoretically overcome it, but but practically that might be harder than it is when we're sort of sitting here in a lecture room thinking it through bit by bit. So there might still be associations that are much harder to overcome than it seems when we're thinking through it in abstraction. And here is a problem, and I'm going to end with a problem, really, because this is something that I haven't resolved, and that I'm interested in how people think about it. I think there's just a tension in part of the reformist destigmatizing agenda that stresses the importance of something having gone wrong in the brain, and that there can be a slip into undermining agency. So if you think back at the Leshner Code about addiction being chronic illness, so I think it's quite easy to move from we should be understanding because people are suffering from a chronic medical condition, which is true, to the conclusion that people are not responsible for their behavior. So you kind of want a sweet spot where you acknowledge challenges to agency without slipping down into saying, okay, so we're just going to ballpark excuse, because that is not doing anybody any favors. And I think that it's just very, very hard conceptually to not go overboard one direction or the other. So that's kind of the problem I want to leave you with, because I think I'm done now. Yes, thank you for listening.